Welcome to GP Trainee Teaching Lockdown Learning Session 3. Thank you very much for all of those that have joined the previous two sessions, and welcome to all of you joining for the first time. So what's going to be happening is, until the lockdown is cleared, because training is being sort of minimized, some people aren't getting VTS teaching, we're going to keep the motivation and the learning going to help you for AKT, CSA, everyday consulting, and post-CCT to start thinking about career. So we'll be running these every week, every Thursday, same time, 7:15 to 8:15, okay? So for those joining for the first time, just a very brief introduction. My name is Dr. Muhibur Rahman. I'm a portfolio GP based here in Birmingham and Solihull. I'm a partner in my own practice. I work in a few other places. I work in community detox. I'm a resident GP in a centre for women with severe mental health, so they're mostly on section. And I'm just finishing my onboarding for the GP clinical COVID assessment service. Okay, and I'm the medical director of eMedic. I spend most of my time now teaching, training, and consulting with organizations like MPS. I teach at Pulse Live and things like that. But I still maintain my clinical work as well. So that's me, and just really want to start with, when this all started, I think a lot of us perhaps were hoping that the lockdown would be over quite quickly. And the longer it drags on, the more challenges it brings. We're seeing that there's still a lot of people getting affected. A lot of our colleagues, doctors, nurses, other healthcare professionals, other people, that we might work with have been affected. And, we know that many have passed away. And it's important to still keep your motivation up, keep your morale up. This is something that we will get through, but we've got to all work together. Now, I just want to share something that my daughter drew, and, we hung in our window. That, look, I know how hard you're all working. The burden of training on top of how hard and challenging the clinical work is immense. I've just got the clinical to deal with. I can't imagine, if I think back to how challenging it was trying to, deal with the portfolio, and especially those who are waiting on exams, having that uncertainty, it's, hugely challenging. So, I just want to highlight that you're probably all aware how much people out there appreciate. And sometimes you see things like this, it just gives you a little bit of a boost that, people are really appreciating the work that we're all doing. So, thank you very much to every one of you. Okay. So on to today's session. In terms of the format, I'm going to cover 3 topics. So we're going to look at 2 clinical topics and 1 careers-related topic. We'll try to keep it interactive, either by me asking you questions, either in a poll format or to answer in the chat, or by doing some interactive casing. Today we're going to start with a case, and then we'll have rapid reviews of the relevant guidelines, how to deal with it in real-life situation, and discussion. Topics today, we're going to look at palliative care, contraception, just a few important bits from contraception. To cover the whole of contraception, we need more than an hour, more than a whole session on its own. And then the non-clinical topic is locum GP work, pros and cons, and then there'll be a Q&A. Okay, so let's start with talking a little bit about palliative care. So what we're going to do is we're going to look at anticipatory care, syringe drivers, and do not attempt resuscitation orders, and a little bit about what you need to know about these things. I'm going to put them all together by sort of doing an interactive case, the kind of thing that actually is really important right now, because we're having these conversations and having to think about, anticipatory care with some of our more vulnerable patients, some of our patients with terminal illness, perhaps bring forward some of those conversations because of the additional risk because of coronavirus. Okay, so we're going to do a little interactive case. Have a quick look at that. Okay, I'm just going to leave you a minute or so to have a look at this information. Okay. This is the kind of information that we presented to you in the CSA. Okay, so that's what we already know about this patient. Okay, and you can see in the CSA, they always tell you the setting. So in this case, it's a home visit. And sometimes it will say you're in out of hours doing a telephone triage. In some cases, it will just say you're doing a regular clinic, okay? But in every CSA case, it's important to remember you're at the level of someone who's already qualified, not at the level of a registrar, not a trainee, okay? So let's make a start, okay? And I want you to think about, this is the patient, this is the information you've got. I'm gonna be the patient, okay? It's a home visit. So in a home visit case, what happens is when you go to 30 Euston Square, the RCGP's headquarters, the exam runs on 3 floors at the same time, 3 circuits, okay? Each circuit has 14 rooms. So there's 13 consulting rooms, 1 for each registrar. And then there's 14th room is set up with a bed and a sofa in it. And in most cases, you stay in your room, you have your notes on your iPad like this, you've got 2 minutes to read, there's a knock on the door, the patient comes in, the examiner comes with the patient, and you've got 10 minutes to do it as much as you can, okay? For a home visit case, you only have 1 minute to read, and the other minute is used by the examiner. They'll take you to the visit room. When the buzzer sounds, you knock, and you go in, okay? So, let me turn that off. So, you're going to knock and you're going to go in rather than the other way. So imagine now you've just come in. Let me just turn that off. Excuse me 1 second. Right, there we are. And if somebody would like to start us off, okay, you've come in, I'll be the patient. I'm going to answer your questions live. So if you want to ask a question, if you want to ask it in the chat, and then I'll try and pick some off and we'll make a start, okay? And you can see here the family requested the visit, okay? So let's make a start. What are some of the first things you want to ask? I'm just waiting for the first question to come through. Okay, so let's imagine we've done the introductions, okay? I appreciate you don't want to do that first, okay? That's very polite and that's great. What's the next question you want to ask? Either ask it in the Q&A or ask it in the chat, okay? There we are, something's coming through. Okay, so let's start at the top. So someone's asking, how am I feeling? Okay, so doc, more than anything, I just feel sick to my stomach. I can't take it anymore, doc. I need some help. That's why I got my son to call you. Okay, so someone's asked, what symptoms I've got? I feel sick all the time. I've been taking the sickness tablets. To be honest, because I'm vomiting so much, I don't know how much of it's staying down, because often I'll take it and then I'm sick straight after. So, there's nothing in my stomach. I can't keep anything down. Even water, I can barely keep down. I'm managing that small sips, but I can't eat anything at all. I'm just sick to my stomach. Someone's asked about pain. Yeah, it's like I got crampy pains in my tummy, doc. It's like a really, really crampy. It comes and goes, but to be honest, now it's there more than it's not there. So, I mean, if that's something you could help with as well, that would be great. Someone's asked, do I feel sick? Yeah, I feel sick all the time, doc. Just all the time I feel sick. I'm vomiting, I don't know, 6-7 times in a day. Someone's asked, am I opening my bowels? Yeah, so I go probably once every 2 days. When I do go, sometimes it's a bit painful as well. But I'm more concerned about this vomiting rather than my bowel stock. That's what I really want help with. Okay, so someone's asked a really good question. How much of the liquid medication I'm used? Doc, I took 1 extra dose yesterday and the day before and the day before. So mostly, I take 1 in the morning, 1 in the evening, the tablet, okay? But because of this pain, it just was so bad. Yesterday, it's sort of like when it's worn off about the middle of the day, because I take 1 in the morning, I take 1 just before bed. In the middle of the day, I couldn't take it. So I took, 1 extra dose of the liquid. So it's like 2 spoons is 1 dose. With that, between the tablet I take in the morning and the evening and the 1 extra dose, my pain was okay. It's more that, even the tablet sometimes, I'm worried that if I'm sicking it up, that it's not going to actually last me overnight, and then it's affecting my sleep because of that. Someone's asked, what about any relation to food? To be honest, I can't keep food down, so I'm just avoiding food, just having small sips. And then my son bought me some of these shakes, so that because I can manage liquids, I'm keeping with that. Someone asked a great question. When did it all start? I think these vomiting, I've been feeling sick for a long time, doc. That's why they gave me the sickness medication, because I've been feeling sick probably for months. But I'd say the vomiting started about 4 days ago. And ever since then, I'm struggling with keeping the food down. Okay. Someone's asked, what have I tried so far? Well, I take the sickness medication. I take sips of water and that shake. I'm just trying to avoid food, really, because I know I'm going to sick it up. And then, that's not nice either. Someone's asked if I've got any diarrhea. So that was answered earlier. No, I'm just going once every 2 days. And it's quite firm, actually. Any difficulty swallowing? I can manage to swallow. So like, for example, I'm having those shakes, they're okay. And then I take my tablets, I manage them, but it's more that I can't have food, not because I can't swallow it, but it's because I vomit it back up afterwards. Okay. Someone's asked, am I passing urine? Yeah, that's no problem, doc. I peeing like normal. Okay. I am really tired though. Okay. Someone's asked, have you got any headaches? That's a really good question. Not really, doc. As I said, I'm feeling quite tired. And sometimes when you're sick, sometimes when you vomit, if you vomit a lot and you're retching, that sometimes causes a bit of headache, but it doesn't last long. It's not like a headache. It's just, I think, because, when you retch, it causes a bit of pressure. That's all. Someone's asked, am I taking any other medications like laxatives? No, just what's on my chart, doc. I take a sickness tablet, and then I have my painkillers morning and evening, and the liquid painkiller when it's really bad. As I said, I've taken that once extra yesterday, the day before, the day before. Okay, nothing else. Someone's asked a good question. Is there any blood in the vomit? No, doc. It's just like, like normal vomit. When I have managed some of the shakes, I can see some of the color of that sometimes. Apart from that, it's like just vomit, quite watery. Someone's asked, what am I worried about? Well, the main thing I'm worried about, doc, is being sick all the time. It's really not pleasant. I'm hungry, but I can't really eat. And then it's just, you're vomiting. It's really leaves a bad taste in the mouth. You don't feel good. I'm already feeling tired anyway. Look, doc, I know I'm near the end. They told me at the last clinic that there's nothing else they can do in terms of active treatment because, they've spread, some of it's gone to the bones. They said that it's too widespread for them to do anything else. And so I appreciate that you're not suddenly going to cure my cancer, but I just want to, I want to have a comfortable death. I don't want to be vomiting up my guts and die in pain. Because I can't take my painkillers and keep the pain under control. Don't get me wrong. If I have them, it is controlling it with the extra dose. But as I said, the vomiting is getting worse. And, that. And then the other thing is, I don't want to go back to hospital, doc. I've been in and out of hospital too many times. The first time before the cancer came back, I had the operation on the one side. Then they said it'd come back. I had chemo, I had radiotherapy. I just fed up. I don't want to go back to hospital. I know I'm near the end, but I want to be surrounded by my family. I want to die peacefully at home. And I just want to be comfortable. I don't want to be in pain. I don't want to vomit my guts up. Can you help? Someone's asked, any changes in the last 4 days? Any fever? So that's a really good question. No, I don't feel hot or sweaty or anything, doc. Just this vomiting. Someone's asked, would I be happy to take medication in another form? Doc, I'd be happy to take anything, just as long as it works. If you can stop this vomiting, keep my pain under control, keep me comfortable and keep me here. I just don't want to go anywhere else. That's what will make me happy, okay? Someone's asked, when did you start the morphine? I've been on the strong painkillers probably about 6 months now. I was on a lower dose first, and then they put it up about 3 months ago, and then put it up again about a month ago. Since then, I was on the one tablet in the morning, one tablet in the evening, and I hadn't really needed the extra liquid one up until the last few days. It sort of tied in with these crampy pains and the vomiting getting worse. Okay. Okay, so someone's thought to ask about, have I thought about dying? I said, doc, I know I'm dying. I accept that. And I'm not scared to die either. I've done my time. I've had a fair innings. I'm 64 now. I've seen not just seen my kids grow up, but, I've seen my grandkids. My eldest grandchild has just finished university. I'm just glad to have got this far. To be honest, when I first got it, they didn't think I'd go past 2 years. That was 5 years ago. So I'm glad to be where I am. I just would like to have a dignified, comfortable death. That's what I would like help with, okay? Someone's asked, have I ever tried a pain patch? No, doc, just these tablets is what I've been on. I was on different tablets before. Ones I used to take every sort of 4 or 5 hours, but now they put me on the one in the morning, one in the evening a few months back. Okay, and it's better. Okay. Someone's asked, have the palliative care team been involved? So yeah, have a Macmillan nurse. She's come to visit a couple of times, and they sort of ask about how I'm coping. They were the ones that actually told the GP that I was being quite sick a lot, and then the GP added in that sickness tablet, which has been really helpful up until recently when I've been sick more. So I think I'm not keeping it down because it's 3 times a day. Often, I've begun being sick so much, I think maybe 1 or 2 of the doses might be staying, but maybe some of it's being vomited back up. Someone's asked, would I want to go to the hospital or hospice to manage my symptoms and go home? Not really, because I'm just scared if I go there and I get worse, I'll never make it back out. I just want to stay home if I can. Okay, I'd like to die at home if I can, but comfortably. Okay. Right, okay, so that's good. I think we'll stop it there. You've asked some very good questions. Let's look at some of the things that would be really important to think about here, and take it from there. So in terms of the data gathering, so some of the things to think about, if we look at the vomiting first, because that was the presenting complaint, right? That was why the home visit was called, is to ask a bit more about that. So, is there any blood? Is there any difficulty swallowing? Any choking? Any things like that? And then, how often they're vomiting, how long that's been going. That's great. You guys already asked that. What could be causing the vomiting? So asking about things like early morning headaches that might make you think about, could it be brain mets? Or, if it gets worse, if they bend over, or if they sort of have got any other symptoms that might make you think, like visual changes that might make you think about brain mets. Okay. Could there be any diarrhea? So could it be a gastroenteritis? It only lasts 4 days. It could be an acute problem on top of the cancer. Your immune system is weakened. You're more prone to get a viral gastroenteritis or even a bacterial gastroenteritis, which could be treated, right? Asking about things like fever. Could there be an acute illness on top of this? And then someone had asked about when they'd last opened their bowels, thinking about, could it be obstruction? Okay. Their primary was in the lung, but you never know. They could have got mets that have spread to the gut, and that could cause a bit of obstruction. It's possible, isn't it? And then in terms of the pain history, the total morphine intake, how often it's been changed, how often they're using the oral morph. So we found out the last 3 days he's needed an extra dose, and that was 10 mils each time. Any side effects of that? Okay. So in terms of examination, what kinds of things would you like to examine for this patient? Type that into the chat. Okay, so I can see a few coming through now. Okay, so people have said, basic obs and vitals, all right. Abdominal exam, because they did have some crampy abdominal pains, checking if they're dehydrated. Neuro, so to see whether or not the vomiting could be brain mets, for example. General physical examination. Mental state, to look at cognitive. So for example, if someone has got brain mets, it might affect their cognitive function. They might not have capacity to make their own decisions. So you might need to do a best interest decision. So things like that. Okay. And then a quick neuro exam. Okay, great. So I think we've got the most important things there. So let's have a look what things would be important here. So yeah, the vital. So blood pressure, pulse might give you some clues. Okay. Oxygen saturations. Bear in mind, he's got a lung cancer primary and there's a history of COPD. So 2 reasons why that would be important to look at. Higher risk for things like respiratory failure as a consequence of his cancer. Temperature, to look at acute causes. Abdominal exam, neuro and cognition, and then chest. Okay, again, to tie in with that breathing. Okay, so let's say now you've done all of that and you find that there's no fever, the SATs are acceptable, the vitals are all within acceptable limits, there's no signs of obstruction, he's got good cognitive function, he's got full capacity, and the chest is as you'd expect of someone with COPD and with lung cancer, but there's no sign of acute infection, i.e. this just looks like it's caused by progression of disease and maybe the mets. All right, there's nothing extra that we're finding there. All right, so let's think about how we might manage this patient. What kinds of things might we think about to manage this patient? Any thoughts? Anyone like to put that down? How are we going to manage? What kinds of things might we think in the management for this patient? Okay, so someone said when to think about pain management, okay, we might think about the route of medication. Someone else said we might think about giving something by syringe driver. Someone else mentioned maybe switching the morphine to oxycodone. Other people are thinking about maybe the DNAR because he strongly said that he doesn't want to go into hospital. Okay, so think about some of those options. Okay, anticipatory meds. All right, so we might think about anticipatory meds. Okay, good. What kinds of medications might you put in a syringe driver for this patient in terms of anticipatory meds? Type that down for me into the chat. So we might think about analgesia. We might think about antiemetics. We might think about a different type of antiemetic, general end-of-life care. Okay, yeah, so a few people have said anticipatory meds. I'm just trying to tease out from you a little bit more detail. Okay, I'll help you along. There's 4 core drugs that when we're thinking about anticipating someone might be close to the end of life and we're trying to prevent them having to go into hospital, for example, we might write some of these things up to prevent an out-of-hours doctor being called out who maybe doesn't know them and doesn't know the family, having to say the whole story again. We might prescribe this so the district nurses can come, or the Macmillan or Marie Curie nurses can come and get it all set up. So it's typically 4 drugs that we put. They're called the just in case 4 core drugs, okay, for anticipatory care. So one of them is diamorphine, great. Someone said midazolam, great. Someone said glycopyrronium, yeah. And a few other people have said buscopan. Some people have said anti-anxiety. So I'm going to go through the specific drugs in a second for you, but actually I like the fact that someone said about anxiety and someone else has said about the nausea. And it's one of the things that I loved so much. I actually left medicine for a while. Okay, after I did my house jobs, I was thinking about career change. I did a master's degree in informatics, and I was studying at UCL, and I was doing some locums in different places. The last 6 months, I didn't have to attend university, so I thought I'll take a full-time job to pay the bills. And I took a job at Birmingham St Mary's Hospice, and it's where I fell back in love with medicine, and why I'm actually still a practicing clinician now. So I never wanted to leave patient care, is because the beauty of palliative care is that everything revolves around, in general practice, we talk about being patient-centered, and that's really important, right? But you really see it in action in palliative care, where from the cleaner to the chief executive and every clinician and every non-clinician in the building, everyone is thinking about the needs of the patient. And we have a big focus on symptoms and how can we manage and control those symptoms to a way to make the patient have a comfortable death. Remember that if a patient dies, that's not a failure on your part or their part or anyone's part. Death is the natural endpoint of life, because life is a terminal disease, right? But when you focus on symptoms, then you can really think, okay, what's causing them? And sometimes you don't need to deal with what's causing it if it's not, if it's a long-term issue, for example. You can just focus on the symptoms. So it's a good way to think about it, to think about the symptoms, right? So we might think about a syringe driver. So something for pain, something for sickness, something for either respiratory secretions, which they might have with their cancer and COPD on top, okay, or the colic. And then if they're getting very restless, which often, like this patient isn't at this stage, but often people do get very near the end of life, okay, involuntarily restless, then anticipating that and prescribing a sedative, an anti-anxiolytic or anxiolytic can be useful, okay? And then, people had already mentioned discussing with the hospice. They want to stay home. That doesn't mean that you don't have to go into hospice. A big role that we had when I worked in palliative care is that we would advise GPs in the community, district nurses in the community, but also hospital doctors for patients that were in hospital, just how to manage some of those symptoms. Is that big focus on symptoms, okay? So once you've done that, you probably want to see them in a couple of days, because this patient may have days to weeks rather than weeks to months, okay? And so, you don't want to leave it a week, 10 days to review. You probably want to review them in 2 or 3 days, maybe even earlier if you need to adjust the dose, if, the symptoms aren't being well controlled, and have a safety net in place that, with them and with their permission, with the family, that if their pain's not controlled or they're getting really drowsy or the vomiting's not settling, not to be scared to call sooner rather than later, so that will come out. Because, perhaps a bit less now, but it used to be before COVID, that a lot of house visits that were done in some practices perhaps weren't necessary, but these are the kinds of house visits that actually it's an honor to do, that you think these are the patients that need a house visit and you really don't mind doing it because it's one of the beautiful parts of GP, being able to help people in their environment and keep them at home. Okay, so let's look at the actual drugs. Okay, before we do that, I want to just recap how much diamorphine we're going to put in. So have a look at this question. Those of you that joined, we did one about pain management before. It's just a revision, but I know a lot of people weren't on that because we've got a lot of people on today that are new. So just have a look at this question, because that's one of the things in CSA you have to manage. You have to be specific. If you just say we're going to put you on a stronger painkiller and a syringe driver, you won't get the marks. Okay. Okay, so what's interesting is that every single answer has been picked. It just highlights this is something we know from the examiners that a lot of doctors find challenging. So every single answer has been picked. The two popular ones were C and E, 40 milligrams and 60 milligrams were the two most popular answers. But every single answer has been picked by a good proportion of people. Okay, so correct answer here would be C, 40 milligrams. Now 40 milligrams not perfect if we do a conversion, but it's close enough. It's the closest one. Okay, this is probably a bit too high to start them on. This isn't going to be enough. Okay, so 3 milligrams of diamorphine in a syringe driver over 24 hours is equivalent to 10 milligrams of oral morphine. Okay, therefore 100 of oral morphine would be 30. Now if you look at this patient, they're already on 120 as their regular dose. 60 modified release twice daily is 120, isn't it? And then they've needed another 20 milligrams each of the last 3 days. So really what they need is about 140 to control their pain. Do you see? So 30 is equivalent to 100. It's not going to be enough. They're going to be in more pain than they're in now. They might not be vomiting, but it's just not enough. Okay, 50 though, 50 will be equivalent to more than 150. So it's like more than they're using now, and so it might be a bit too much for them. All right, so and 60, which was the other popular answer, is way too much. 60 is equivalent to 200. Okay, it's a lot more they're on now. So whereas 40 is equivalent to about 140 something. Okay, 140, what they're exactly on is equivalent to about 42 or something like that. Okay, so 10 milligrams of oral morphine is 3 milligrams of diamorphine subcut. So therefore 140 milligrams is about 40, about 42. Okay, so that's close enough. You'd start them on that, and then the breakthrough dose, if he's vomiting, you don't want him to use oral morph. Okay, although he's saying that is, managing at the moment, it may get worse, right? As they get closer to the end of life, they might find that they can't actually swallow either. And so also subcut is quicker. All right, so giving a subcut dose, usually you'd give 1/10 to 1/6 of the 24-hour dose. So if he's on a 40 milligrams of diamorphine, you can use diamorphine subcut if you want, or you could use oral morphine. If you're going to use diamorphine, then you want to use 1/10 to 1/6. So somewhere between 4 to 6 milligrams you could use as a bolus dose, okay, as a top-up. Okay, let's look at these 4 drugs. So if you're going to put up a syringe driver, this is called the just-in-case 4 core drugs that, sometimes called anticipatory meds that you might write up. Not necessarily all of them are going to be actually put up into the syringe driver, but if they're written up and ready, they could be added then without having to call out another doctor. You could just, it's already ready to go. You could advise then over the phone, for example, okay, start it now. So if someone is totally opioid naive, i.e. they're not already on regular opioids, they're not already on some morphine, and you need to manage pain and you're just starting them on diamorphine, you want to start on a very low dose. So, you might start with just 10. That's equivalent to about, sort of just over 30, about 33 milligrams of morphine orally in 24 hours. It's not a huge amount, all right? But if they're already on morphine and that's controlling the pain, then you do the conversion like we've just done to the equivalent amount, okay? So that's going to be to deal with the symptom of pain. then levomepromazine, somewhere between 5 and 12.5 milligrams. You could go up later on to 25 milligrams, okay? But as a starting dose over 24 hours, somewhere between 5 and 12.5, depending on how big the patient is, their age, things like that. And this is for nausea and vomiting. So this is probably one of the most important ones for this patient, is the diamorphine and the levomepromazine, because their main symptoms are pain and the vomiting, okay? Midazolam, a small dose, 10 to 20 milligrams over 24 hours, is for restlessness. So you might prescribe this, but not start it at this point for this particular patient. But you might have a patient who's closer to the end of life, who's already restless. That could be very useful. And then glycopyrronium, which can be used for two things: excess respiratory secretions, which people often get closer to the end of life. Okay, they get sort of quite rattly. And then for this patient, this sort of colicky type pain that they describe, it's also very useful for that. So it sort of has two functions, okay? And the starting dose is somewhere between 0.6 and 1.2 milligrams over 24 hours, okay? So these are the just in case 4 core drugs for anticipatory care, end of life care. Now, you might be that locally you have different drugs that they commonly use. One of the reasons that this is recognized as a fairly good starting base is that not all drugs mix well in a syringe driver. Sometimes if you mix the wrong drugs, they crystallize and then the patient can have a reaction. They won't go through. If you think about subcut, the needle is very small, okay? So even if it solidifies a little bit, it can be quite difficult. Some of these practical things you have to think about, and it's one of the things we have to always think about in the hospice when we had a lot of patients on syringe drivers, is which drugs mix. So these 4 can mix in a syringe driver without crystallizing, without causing a reaction, okay? Now, in terms of interpersonal, one of the things that people talked about is examining their cognitive function, okay, to assess, are they able to make their own decisions? And then we want to start thinking about respecting the patient's wishes about admission and about further treatment, and thinking about that discussion about do not attempt resuscitation if it's not already been discussed, and type of sensitive approach to that. All right, okay. So I'm going to try something. I'm not sure if this will work. If it doesn't, I'll just give you an example of how you might do it. But is there anybody that would like to have a go at explaining it to me? So I'm the patient, okay? It needs to be someone that's got a microphone, all right? Let me see if that would work. No, I don't think that'll work. Okay, no problem. I'll just type it into the chat. I'll just reopen the chat. What are some of the ways, type it as a specific question. How might you start that discussion, or how might you ask a patient? Because if you suddenly say, if your heart stops, should we resuscitate you or not, just bluntly like that, then it might really upset them and the family, and you want to be sensitive, right? Okay, so if you think about the interpersonal part of this, can anyone think of any specific ways that you might start that discussion? Okay, just type that in the chat and I'll see what people think. And it's public chat, so other people can see as well. People might have some really good reasons or ways to do it. While I'm waiting for that, someone's asked a really good question. What are the indications for a syringe driver? Okay, so the 2 main indications for a syringe driver. One would be that the patient can't swallow. Imagine someone, for example, with an esophageal cancer, or someone who, just because of how weak they are, they can't actually swallow oral meds anymore. And so, you want a different route. And so a syringe driver might be one of those. So that's one. The other is like this one. If someone's vomiting so much that, although they're not having difficulty swallowing, so you're not worrying about choking, but if they're vomiting so much that, one, the vomiting is itself a problem, and so you can't manage that with oral medication that you would normally use, like cyclizine or prochlorperazine, you want a different route. And because of the fact that you can't control pain. And the other is that when people are very close to the end of life, often they can't take lots of medication. They can't cope with lots of tablets, and they don't want lots of people coming in and sort of giving them those tablets every 4 hours, every 6 hours. With the syringe driver, it's set up, it lasts 24 hours. So you need to have someone come in and check it once every 24 hours and top it up. So it can be very, very useful for when people are very close to the end of life. Okay. So let me just have a look what people have put in the chat. Okay, so people have said about some very good phrases coming up. So someone said, have you ever thought about what you want to do when things get worse? Or have you ever thought about how you'd want to be managed in case your heart stops? Or have you had any thoughts as to how you'd like us to treat you in the event that your heart stops? if you became less well than you were at this point, what would be your priority? Some very nice phrasing here. Okay, so great. So yeah, that's some very, very good examples. So I'll just put all of that together and give you an example of how you might approach this discussion. So something that could be really useful is to reflect back some of the things that they've said themselves. It's a way to show them that you're really listening, that you're paying attention, but also they're much more likely to respond well to it. So for example, this patient said a couple of times, I really don't want to die in hospital. I really don't want to go back to hospital. You could use that. You've said a couple of times that you really don't want to go back to hospital and that you didn't even want to go into the hospice, that you'd like to stay at home. Now, one of the things that can happen with someone with your illness is as the illness gets worse, as the illness progresses, it might start affecting other parts of your body. So for example, sometimes it can affect the heart, sometimes it can affect your breathing, and so sometimes the heart can stop and sometimes your breathing can stop. If that was to happen to you, what would you like us to do? How would you like us to approach that? And you can just leave it open like that. And sometimes they'll say, well, what do you mean? And then you might clarify, well, there are a couple of options. Some people, while they know their cancer can't be treated, they would still want us to try to revive them, to get them heart started again, get their breathing started again, so that they might have a bit more time with their families. Other people would rather that we just let them die peacefully and that they don't want that to happen. But it's a personal choice and it's a decision that's different for different people. What are your thoughts about it? You can see by offering choice, by giving options, they're a lot more involved. By using their own words, it's clear you were listening earlier. Again, it's quite person-centered, okay? And you're not making a decision for them, but you're also being sensitive about how you choose your words, okay? So, I've taken some of the things that you guys have put, some very, very nice phrasing there, okay? And I'll leave that in the public chat for others to see as to how you might, discuss that. And then just thinking more generally about DNAR, a couple of things that are really important. The default rule should be that we should involve the patient and stroke or the family, depending on what the patient wants, unless there's exceptional circumstances. Now, we always had a professional duty, okay? But after the Trainee case of 2014, I won't go into the details of that case, but feel free to look it up, Trainee 2014. It's a landmark case. After that went to the Court of Appeal, we now have a legal duty that we should involve the patient and stroke or the family, unless it's exceptional circumstances. What is exceptional circumstances? You think that having that discussion will be so detrimental to their psychological, mental, or physical health. You think that they're going to be so upset they might jump out the window, okay? Or that they might do something drastic that would actually make their situation worse. Then you might avoid it. But in almost every other circumstance, you should involve them in that discussion. You should not avoid the discussion just because you think that they're going to be upset. Of course they're going to be upset. But that's where you have to do your job in a sensitive, in a professional way, where you build up, you give some warnings, you're sensitive, you choose your words, you involve them, you offer them the choice to have someone with them if they want to go over it more than once, to give them information afterwards and then come back and discuss it further if they want to. All of these things. Like imagine if I tell someone who has just been diagnosed with breast cancer about their diagnosis. Of course they're going to be upset. So I'm going to give warnings, I'm going to build up, I'm going to be sensitive, right? I'm not going to not tell them because they might be upset. You see, that isn't a good reason not to discuss something so important with someone, okay? And I worked in palliative care for a long time before I became a GP. I've had this discussion many times, and I've not once this is coming up to, it's my 19th year of doctoring. Okay, I've not once had a patient where it was inappropriate to involve them in the discussion. All right, I'm not saying it could never happen. There could be a few exceptional circumstances, but the norm should be that you should involve them in that discussion. Okay, and by anticipating and discussing it early, it can really allow a more dignified death and it allows to respect patient choice. If we look at the research, over 2/3 of patients say that they would prefer to die at home. Actually, how many end up dying in hospital? It's the other way. Over 2/3 of patients, actually about 3/4 in the UK, end up dying in hospital. Someone's asked, is it appropriate to resuscitate someone who's palliative? It could be. And that's something really important, that we don't make a blanket decision, and that just because someone's near the end of life, we should not treat them differently because of the ethical principle of justice to someone who's not near the end of life. It depends, okay? And someone could be near the end of life for a year, for longer, and so it depends on an individual circumstance. Look, when I worked in orthopedics, we had patients who had fractured neck of femur, okay, who were elderly, terminal, had cancers, other things, and we'll do a palliative fixation. It's a big operation, right? Just for the pain relief. So sometimes resuscitation might be appropriate. Okay, sometimes it might not be, but that's why you involve them in that discussion. Okay, and then it's important that you document it. Now, here there's a lot of local variation. So in some places they use the respect form. In some cases you have a different form in the community than in hospital, and it's important that you know your local situations. Okay, so that's something really, really important. Okay, so it's 8 o'clock now. A few people have requested that we just take a pause here. You might hear outside some people are banging pans and clap. So feel free to join in if you want. We'll do it for a minute, okay? It's just turned 8 o'clock now. You might hear it outside, but we'll do it now, shall we, okay? So huge thank you to every single one of you and all of our colleagues out there, and not just the ones that we're working with, but the fallen, they shall not be forgotten. Okay, so thank you very much, everyone. Okay, hugely appreciated. Feel free to join in if you want to. Feel free if you don't want to join in. That's also okay. But you might hear it outside my window. Okay, you can see someone's putting fireworks on. They've taken it to the next level. Okay, so thank you very much, everyone. All right. So any questions on that before we move on to the next section? So we've actually already been at it nearly 45 minutes. As I said, I want to spend a bit more time on couple of the other things as well. So I want to talk about missed pills in terms of contraception and emergency contraception. So I'm not going to cover the whole of contraception. That will need a whole hour and a half in itself. Just want to talk about these two things because people often struggle with these two things. So let me start with emergency contraception, and then I'm going to come back to missed pill. Have a look at this question. And that's time. Okay, so I'm going to just close that poll. Thank you. Okay, so the most popular answers were A and D. So copper coil, leave an gestrel, and start the combined pill today. These were the two most popular answers. We did have someone pick, a few people pick allopurinol acetate, LO1, and then start the combined pill in 5 days' time. Okay, so the correct answer is A, the copper coil. A couple of reasons for that. So this patient, she's breastfeeding and she doesn't want to stop. Okay, if you have the copper coil, there's two reasons why it's the most suitable option in this situation. One is that it has no hormones, so you don't have to stop breastfeeding at all. With levonorgestrel, you only have to stop breastfeeding for 8 hours. So if they didn't want, some people don't like the idea of a coil, they want something oral, then levonorgestrel is better than allopurinol acetate. Allopurinol acetate you have to stop for much longer than that, okay, because it's got a much longer half-life, okay. With levonorgestrel, it's just 8 hours, so you could express, it's probably only a few feeds, okay, 1 day basically. Copper coil you don't have to worry about at all. Also offers long-term contraception. But the other reason is that in this particular scenario, while it says that she had this episode 2 days ago, she's day 14 of a 28-day cycle, so she's likely to have ovulated. Then the copper coil is the best option because it can be used after they've ovulated. On top of that, it's 10 times more effective at preventing pregnancy than either levonorgestrel or allopurinol acetate. All three of them are within the window because it was 2 days ago. But that's why the copper coil is the best option. Okay, and that was the most popular answer. So this is one of those things actually, when I understood the mechanism, it was like a revelation to me. It made it so much easier in real life to make the right choice as to what I offer people. Okay, so oral emergency contraception, the way that they work is that they delay ovulation. So they work best early on in the cycle. Beyond about the halfway point, when the patient is likely to have ovulated, very limited chance that they're going to work. And once you're after the halfway point, they're probably not going to work at all. Why? Because the mechanism of action is to delay ovulation. If they've already ovulated and the egg's already on its way, it won't do anything. It's not going to stop implantation. Okay, so they're good in the first half of the cycle. Levonorgestrel within 3 days, so 72 hours. If they're breastfeeding, they need to stop for just 8 hours. Allopurinol acetate, 5-day window, but they need to stop breastfeeding for a week because it's got a long half-life. Okay, copper coil, how it works is it prevents implantation. So even if they've ovulated, you can still use it up to 5 days after when you think they would have ovulated. So you could use it past the halfway point in the cycle because it will stop them implanting. All right. Whereas, once you're in the second half, levonorgestrel and allopurinol acetate, they're not going to work because of the fact that they've probably ovulated now. And if they have ovulated, they won't do anything. All right. On top of that, the copper coil is, as I said, 10 times more effective, also offers long-term contraception, and there's nothing to worry about in terms of breastfeeding at all because there are no hormones involved. Okay. And then the quick start protocol. So someone had mentioned starting contraception at the same time. So the quick start protocol is where you start contraception the day you see the patient. As long as you're confident they're already not pregnant, you start it the day you see them rather than waiting till the first day of the next period. The only things to think about is if you're going to start them on the combined pill, like microgynon, then they need 7 days of condoms before they're going to be protected. With the mini pill, the progesterone-only pill, they need 2 days of condoms, and then they're protected from pregnancy. Okay. Now you can combine this with emergency contraception. So if they're having oral emergency contraception, like levonorgestrel, you could give them a packet of microgynon as well and say, just start taking this at the same time. But for 7 days, you won't be protected. But if you use allopurinol acetate, they've got to wait 5 days. Now it's easy to remember. Just remember the number 5. 5-day cycle. About 5 days it lasts in the breast milk. It's a week, right? So about 5 days. And then after they've had allopurinol acetate, they wait 5 days and then they start their long-term contraception, whether that's the combined pill or the mini pill. You've got to wait 5 days. Okay, so just remember the number 5 for allopurinol acetate. Okay, really common area that people often get stuck off, whether it's in a CSA case, whether it's an AKT question, whether it's everyday consulting, is the missed pill rules are quite complex, aren't they? Are they in week 1 of taking the pill, week 2 of taking the pill, week 3 of taking the pill? Have they missed 1 pill? Have they missed 2 pills, more than 2, and so on? So I've made some really easy to remember guidance. And then what I tell patients is even simpler than this. Okay. So if they miss 1 pill, this is for the combined pill. If they miss 1 pill, they should take it as soon as they remember, even if that means taking 2 at the same time. Like let's say they miss Monday entirely. Tuesday morning, they realize, I forgot Monday. Take Monday and Tuesday at the same time. 2 pills in one go, glass of water, they're done. And then just keep going. It's as if it didn't happen. They don't need to worry about emergency contraception. They're still covered. They don't need to worry about additional precautions for the next 7 days. Nothing's changed. It's as if it never happened. That's if they've missed just 1 pill. If they miss 2 pills or more in any point in the cycle, they will always need additional precautions for 7 days, i.e. condoms. Doesn't matter where they are in the cycle. And then if they've missed 2 or more pills in week 1 of taking the pill, if they've had unprotected intercourse, they're going to need emergency contraception. Okay. If they've missed pills in week 3 of taking the pill, so week 3 is normally, you take it week 1, you take it week 2, you take it week 3, then week 4 you have a break. That's when you have your withdrawal bleed, right? Then you start back again. So if it's missed in week 3, i.e. they're due to have a break next week, they should omit the pill-free week and run the packets together without a gap, i.e. take the next 3 weeks without a gap, okay? And then take their break. If you follow these rules, you will get the right answer for any missed pill question for the combined oral contraceptive pill, okay? It will give you the right answer. What I tell patients is even more simple, that if they ever miss 1 pill, just take it as soon as you remember. Even if you have to take 2 at the same time, it's safe and it's fine and nothing else has changed. You can just carry on. But if you ever miss 2 or more, just give me a call. And then I contact them and I work out where they are. I don't talk about week 1, week 2, week 3 with patients. I don't use that language. It's very confusing. I'm using that because you're all doctors and you know what I mean, week 1 of taking the pill. But also it means if you use the Faculty of Sexual and Reproductive Health algorithm, it will match up their week 1 and week 3. Okay. The reason I don't use that is most women would consider day 1 of their cycle the day they start their period. And you'd expect day 1 to be in week 1, wouldn't you? That would be logical. But when is the day they bleed for people who are on the combined pill? It's in week 4, the week when they don't take the pill. That's confusing. So I don't use that language. I just say that if you miss 2 or more, just give us a call. And then I'll go through the history and I'll work out if I need to ask them to come in to have emergency contraception, if I need to tell them to omit the pill-free week. If I need to change anything, I'll advise them. So that's what I do in real life, when I have this situation. Okay, so I hope that helps in terms of the missed pill rules. Okay. Someone's asked, can you take emergency contraception and then continue the combined pill straight away? Yeah. Unless it's allopuryl acetate, then you need a 5-day gap. If you're doing levonorgestrel, you can do it straight away. If you've got the copper coil, of course, you don't need any oral contraception, because the copper coil is contraception in itself, isn't it? Okay. Right. Last thing I want to talk about is a non-career thing, and that's Locum GP. So the advantages and disadvantages, and then an overview of Locum GP. And we'll do this for about 10 minutes. Okay. So I apologize because I had to just get the slides and we stopped for the clap. We're going to finish at about 5 minutes over. Okay, so we should finish about 2:20. Okay, I hope that's okay. So if I start with advantages and disadvantages, let's start with advantages. Okay, I'll just put the chat on. Type any advantages that you can think of being a locum GP after you finish your GP training. What are the benefits, good things, pros, advantages of working as a freelance or locum GP? Okay, so I can see some of those are coming through. So some people have said that flexibility. Lots of people have said that actually. You can choose your own timetable. You're not bound to one practice. Someone said that you can get more money per hour. You can work at your own pace. Lots of people saying flexibility. You're more independent. You can choose when to work. Someone said no admin. That's actually not true. There's a different admin. You'll have a lot more admin than, say, as a salaried in terms of managing your money, because you're going to have to do that all of yourself. Invoicing, pensions, all of that you'll have to do yourself. And you'll still have to do admin for your own patients, but there's less of the sort of admin like QOF and the practice management stuff. You can experience a range of different practices before you decide to settle in one place. You can choose your own time. Someone asked, have you been a locum GP at any point in your career? Since I became a GP in 2007, for the last 13 years, I've been a locum GP alongside my other roles. I only opened my own practice and became a partner 3.5 years ago. Okay, and now that's my main clinical role. Within that, I do lots of different things. I work in community detox. I'm the resident GP, as I mentioned, at a secure unit. Our practice specializes in sexual health, so I do a lot of sexual health work. But I still do the odd locum elsewhere. Less and less now. But for the first 10 years, I almost exclusively did my clinical work as a locum. Someone's asked about getting to know different practices. Can choose a mixture of different places. It's more flexible if you want to develop a portfolio career. Fantastic. Yeah, so I think you guys have got a lot of the main advantages. So you've got the flexibility that if you want to not work any Fridays, you could just not book yourself or make yourself available any Fridays. Okay. If you want to take a month off and then work really hard at other times to make up for that, you don't have to ask anyone's permission to take that month off. Just don't. So for the last 13 odd years, I haven't worked in Ramadan is just entering, actually, the month of fasting. I just shut down, apart from my core clinics at my own place. I just don't take any additional roles. I don't take any additional locums. I just say no to all the offers. Okay. Now, of course, that means I make much less that month, but I've got other things I want to focus on, and it allows me to do that. Okay. And I might work harder other times of the year to make it up. But you don't have to ask anyone, can I take? Whereas in most practices, it'd be difficult for you to ask for a month off, right? Okay. You can control your own workload. So if you want to work 6 days, you could. If you want to only work 2 days and you're able to manage on that, and accept that you're going to get less income, you can do that. Okay. If you never want to work mornings, you could only make yourself available to book afternoons. Money per hour, locums will usually earn more than partners or salaries per hour. Okay. A lot of partners will make more overall, but they'll put a lot more hours in. But certainly, if you're working full time as a locum, 40 hours, making 125,000 pounds a year, very manageable. And I know a few locums that, as part of a portfolio career, that are working really hard and being smart and efficient in how they roll, that earn much more than that. But certainly, you could work 4 days a week, have 6 weeks of leave a year, and still comfortably make £100,000 as a locum. Okay, it's definitely achievable. You're self-employed, so you can take leave when you want to. Okay, it can be interesting to see different styles, before you commit to somewhere long term. You also can learn. Like I locumed in so many different places, and before I opened my own practice, as I said, I'd been a locum and been qualified as a GP 2007. Nearly 10 years before I opened my own practice. I'd seen some things in some practice. I thought I really like the way they did that, and we might have incorporated that in our practice. I'd seen some things in other practice. I thought I really don't like that. I'm going to make sure if I have my own place one day, I don't want to do those things. Okay, but also if you want to take a job somewhere else, these are some of the things that okay, I'm going to ask about this. So one of the things I found is places where they regularly all meet for coffee at some point in the day. You almost always find that people get on well and it's a happy practice. Places that say, you know what, we would like to meet, but we can't because we're too busy. What you find is they're too busy for that. They're also going to be disorganized. And because they're not meeting, they don't fix things when they're this big. They wait till they build up and they're this big. Then they're trying to manage a crisis. Prevention is better than cure. Practices that meet together, that eat together, they stay together. Okay. So those are the advantages. What about disadvantages? Any downsides? Because if there are only advantages, everyone would locum. There would be no one that wanted to do anything else, right? But there's no job that's better or worse than another. It's not better or worse being a locum than a partner, than a salaried. It's what's right for you, right? So there's pros and cons of every job. So I want you to think about, so someone said no sick pay. Yeah, absolutely. Imagine that you were self-isolating for 2 weeks, or you got symptoms. If you're locum, you won't get any income in that period, okay? No one's going to pay you. Or if you're salaried, you're going to have sick pay. If you're a partner, in most cases, you're going to have sick pay. Okay. No study leave. Yeah. No one's going to pay you to go on a course. But also, if you go on a course, you're going to lose income that day. You're not going to get paid to go. Whereas as a salaried, you should have paid CPD time. Okay. Someone said that no maternity leave. Yeah. So you can have maternity leave, but you won't get occupational maternity pay. Again, you've got to build that into your budget. That if you're going to take off a year, or take off 9 months, you've got to have enough money to get by and save up, because no one's going to give you money. You could apply for maternity allowance from the government. It's a very small amount. Lack of continuity. That can be an issue if you're doing lots of ad hoc locums in different places. But one of the things that most experienced locums find is what I call the 80-20 rule. 80% of your work will be from 20% of practices. So like there were 3 or 4 practices that would regularly book me, and I would have patients wait until they knew I was coming back. And some practices where I was there every week on the same day. So I had my regulars that would come and see me. And then there'd be some practices that you might go back 3 or 4 times. Some that you might do once or twice a year. Some that you do there once and you never go back again. Okay, so you can build up some content, but it's not the same as when you've got your own patients and your own list. Like one of the things I've really enjoyed is, at that secure unit, I've really got to know all of my patients now, and seeing the changes in things that we did 3 years ago now and the impact on their health. That's one of the beauties of general practice and continuity. Seeing that what you do now, the seeds that you plant now, what grows from it years later. Someone said feeling isolated. Yeah, so in a lot of cases as a locum, you go in, the practice manager or the receptionist gives you your password and takes you to the room. You see your patients, and then you go home. You don't see any other clinicians. You don't see, you don't get invited to the meeting sometimes, okay? And so you often don't have that camaraderie and that sort of, the sort of things that are outside of the clinical, that it's nice sometimes just to talk to another clinician about a case or just about how things are. Sometimes just to moan together, misery loves company. You've had a really hard session, you talk to someone else and realize, whoa, they're getting caned too. It's just that GP is really busy. Everyone's getting caned. Actually, I should be grateful. It sounds like they were worse than me, all right? Someone's talked about the fact that you might have to travel further. Yeah, if you want to work 5 days, you might not have places that are really close to you that are going to give you 5 days worth of work. So you might have to travel for some days. And so getting used to different teams, different ways of working, even if you're used to the computer system, every practice has adapted their EMIS slightly differently, or their system one slightly differently. Or if you're unlucky and you work in a practice with vision, they've adapted that too, okay? And sometimes jumping from one system to another, that can be quite challenging, okay? Someone said that you might have to pay more tax. You might do. Actually, sometimes you can pay less tax. It depends on your structure, okay? So let's look at some of the disadvantages. Yeah, there's no certainty. A really good example is now. Some practices, because now they're not really seeing people face to face unless they absolutely have to, and they're managing with telephone trials. Some practices are just not booking any locums. There are some locums that actually can't get work right now. You'd think that there'd be a huge demand, but because a lot of people aren't going to GP unless it's drastic, the number of contacts is reduced. Okay, and also because routine things aren't happening in hospital, a lot of the things like dealing with follow-ups, people have been to clinic for follow-up, routine, not admissions. A lot of those things aren't happening. Okay, so there's no guarantee of how much you're going to get from 1 month to the next. All right. Some days you're working 5 days, some weeks you're working 3 days, some weeks you're working, Monday to Friday all day. Some weeks you've only got mornings. Some weeks you have to travel really far. There isn't a fixed pattern, so it can make it difficult to plan. Whereas if you're salaried, let's say you're salaried 3 days, they're the same 3 days, makes it easy for you to plan childcare. You know exactly how much income will hit your account at the end of the month, every single month. As a locum, some months you get loads. In the holidays, everyone wants cover. I turn away 10 locums for every one I accept. Other months, you might want to work full time, but you might not fill your diary. Okay. You might need to travel. That travel time is dead time. You're not getting paid for it. You're, not doing anything often productive in that time. You can feel isolated. There can be a lack of stability. You don't have any employment rights. So no maternity pay, no redundancy, no sick pay, no, none of those things. Okay. CPD and education. Sometimes when you're salaried or a partner, they'll be in-house, like the practice will run their own CPD. As a locum, often you'll be covering, and that's why they're doing that. Few practices shut down to get locums to cover, and then they will go off to another place and do like an educational meeting. So sometimes you won't get a chance to go to these things. And there used to be these things, going back probably 10, 15 years ago, where some people used to look down on locums. They used to say, oh, yeah, that person's just a locum. It's the other way now. I've seen a lot of partners leaving partnerships to locum because they want the advantages. Okay, and so I see now the other way, that people don't locum until they can get a proper job. It is a proper job. It's a genuine career choice. I've seen people who choose to locum their whole career. Okay, I've locumed since I qualified as a GP. I've known people that have locumed for 20 years plus, and as I mentioned, it's not better or worse. It's just a different role. That's something I want you to remember. Okay, that it's just something different. Now we cover this and then some of the details of like how to set your terms and conditions, how to set your rates, the 125k locum case study, the 100k locum, the 75k locum, why sometimes it's better to earn slightly less if you want to be in the NHS pension, because you just go over the threshold, you're actually working for free almost, how to negotiate, how to stay outside of IR35. Is it worth setting up a limited company? We cover all of this in huge detail. It's the longest session actually at our CCT Plus course for newly qualified GPs and people who are about to finish, which is going to run in the summer. Okay, so if you want the more detail of that, feel free to come to that. It's a huge session. It's like the longest session we do. That whole day is about 7 hours. Okay, so just to recap some of the basics, there's lots of different options. Sometimes you could be self-employed, so you find your own work, you directly contact practices, you manage your own diary, your invoicing, your pension paperwork, and you can pension work as a locum if you're doing it directly within an NHS practice without going through an agency or a limited company. There's hybrid, so you go through an introduction service like Lantern, okay, or Peru, or a Chambers, where a group of locums work together. They pay a proportion of their income into a pot to hire a manager who does the paperwork and bookings for them. You could set up your own limited company. In some cases, it can be tax efficient. In some cases, actually, you'd lose money. It's not worth doing. Or you could go through an agency so that they've already found the work, but then you can't put that money into the NHS pension. Equally, if you go through a limited company, you can't do that. Indemnity is a lot more for a locum GP than a salaried, okay? And a salaried, in most cases, your practice will pay it. As a locum, you're always going to be paying it yourself. So it's going to be somewhere between 1,000 and 3,000 plus, depending what roles you're doing, how much out of hours, and so on. Your pension contribution as a locum is going to be 14.5% if you're in the NHS pension for most locums, unless you're working very, very part-time. And the income is hugely variable, from as little as £50 an hour to £120 an hour plus, depending on who you are, what skills, what surgery, is it short notice, how much, are they struggling to find someone? But as I said, it's definitely possible. If you're willing to put 40 hours a week in, you could still have 6 to 8 weeks holiday and still make 125k plus as a locum. Okay, so any questions, put them in the Q&A. I'll stay back for that, but let me do a summary because we've just gone over an hour. Just before we do, please do join the GP Training Support Group. If you didn't already join, there'll be a link to it when we finish, okay? I will send the video and the slides. They'll be emailed tomorrow. Do register for next week, okay? In the feedback request, we'll ask you to say what topics you'd like, and then we'll finalize that tomorrow before I send out the invites. We're going to keep going, same time, 7:15 to 8:15, for the foreseeable future. Okay, hopefully until things improve. Okay, so I hope it's been helpful. Just a final reminder that until lockdown's over, for any of you that want to use our MRCGP webinars or our online courses or online revision or our case cards for AKT and CSA, we will give a 20% discount. Just use the code LOCKDOWN. So just go to our website, emedica.co.uk, and you can find all of those things. Okay. And lastly, I just want to say, thank you very much again. Keep safe. Okay. Thank you for everything that you do. It is appreciated by, all of your colleagues, myself, everyone else, but also by the public. Okay. So thank you very much. Thank you for joining me. I hope it's been helpful. I hope to see you next week. Thank you so much. Okay. Preparing you will succeed.